What really one of the things we want to do today is to immediately have you guys see the future. And Cheryl showed some great examples of that. Hannah's one of them. But once you guys realize it's not what the baby's born with, it's what the baby's going to look like after all of our working together and helping and doing the things they need. And then you show the mom before and after pictures, and you guys know what's going to happen, so you confidently can give hope to the parents. And we're going to have all this up on the website. So again, today we're going to give you a lot of technical stuff, but it's mostly to give you a 30,000-foot view of everything that goes into it. And as you can see, it's not a simple thing like kicking into the operating room to fix one lip or one palate. It's a comprehensive team program that goes on sometimes before birth. And I think the question about the ultrasound, we're diagnosing it more and more, and ultrasound is much better than it used to be, so we can tell if a baby has a cleft and prepare the mother. We can tell if it's a unilateral or bilateral, so that definitely does help. It doesn't help so much after birth, but it definitely helps in preparing everybody for what's coming, and not having the baby, not having the parents and everybody with immediate shock. But again, the immediate shock can immediately be put to rest when the doctors and nurses delivering the baby have the perspective of what is in store for the child. Okay, so this is Hannah. That was Hannah before. This is Hannah now. She is in her 20s now. She's married. She would tell moms that she was blessed to be born with a cleft lip and palate because she had a loving family and access to the kind of care that every baby who's born in Belize will have access to now. And it actually made her a stronger person, because as long as they are supported by the kind of treatment that is necessary, and even more importantly than that, I always tell my families that what I do for your child will be important, but far less important than what you can do for them by showing them love and giving them confidence and knowing that that they're not different from everybody else. They're better, because they're going to develop the character and the strength that comes through this. And it takes a lot of support, but if the parents are always there feeding that confidence into the child, and if they can share that with their friends that they get close to, it really makes a world of difference when you have that team of people working all for the same goal. So anyway, Hannah's story is a story of hope, and she's living a perfectly normal life that has had many blessings. That's a picture of Hannah in Haiti when she was 16 years old. Her parents came to me, who became very close to me because I was taking care of Hannah, and they said, Hannah really wants to go with Leap on a mission trip, and is that okay? And we said, sure, we'll make sure that she gets taken great care of. And so she went with us to Haiti, and on the day we were screening patients, like we were doing here in Belize last night, a mother was just bawling her eyes out in the waiting room, and we had a Haitian translator with us who went out there and said, what's going on with this mother? And she had a little baby girl. This is Kalita, the little baby girl, and she says, oh, my baby's never going to be normal. She's not going to have a normal life. Why did God do this to her? Is there any hope? And Cliff, our Haitian translator, said, I have just the thing for this mom. So he ran back and he got Hannah, and he took Hannah out to her. And the mom said, why did you bring this beautiful young lady to me? What does she have to do with my daughter? And Cliff said, Hannah was born with exactly the same thing as your daughter, and your daughter's going to be as beautiful as Hannah when she grows up. And that just kind of sealed the icing of the cake and changed everything for mom. And then we got to do Kalita surgery, and Hannah, this was about 10 years ago, and you can see that she's got her braces on. And so Cheryl's work in orthodontics is very, very important. From, the surgeon does 4 to 6 operations over 18 years. Cheryl takes a small break between 3 months and 3 years of age, but is pretty much involved in orthodontically in the care of the child. And she's going to help us do what we need to do to get that done here in Belize. So most of the babies born with a cleft palate don't have a problem breathing. They can, and I'm sure you guys are very good at identifying when that happens and sometimes the tongue can go up into the palate like Dr. Sermon said and block the breathing a little bit, but it's usually, the airway is usually not a problem. If anything, the airway is more open because the lip and the nose are all connected if it's a cleft palate. But that's the thing you pay attention to first. When we go to countries where we haven't been, for example, India and Zimbabwe, when we first started going there, we saw a lot of malnourished patients. And that's where Diane's talk is going to come in. It's really, really important because they can't generate the suction force if they have a cleft palate through breastfeeding. Something else has to be done, and there's very simple things, whether it's a mother taking a spoon and spoon feeding a baby. We're going to have the special bottles that Diane's going to leave here, which are specifically made for that a little gentle pressure can be added to it. There was one baby in Belize many, many years ago who had a great story that mom brought him in and said, he knows how to drink, he puts his finger in his mouth and he blocks off the roof of his palate and then he can drink. That's one of the things we really have to pay attention to because the ideal time to operate on a baby is when they're 3 to 4 months old. As you can see, it'll be done at any time, but that's the time where we can put all things into progress that'll give the child a normal life and let them socialize as early as possible. There's people on the Zoom call not from Orange Walk, and we want this program to be nationwide. And the initial contact can be through Diane and her counter director here in Belize, who has yet to be determined. We can make arrangements to do a lot of stuff online or by WhatsApp, but the person working at this hospital will be able to see babies and meet with the mother firsthand and get the baby ready for surgery. So this program really is for every part of Belize, and we realize that there's traveling and logistical portions, but we want to make it work in whatever way we can. So I don't want to get too technical, but this is kind of a list of things we do. We want to make sure the baby is nourished and healthy for the operation, which is usually done about 3 months of age. When a baby has a cleft palate, the ears don't drain normally because the eustachian tube drains into the palate, and because of the separation, it frequently collects fluid, so it's very important. And again, this is something that we're going to have as part of our program. A lot of times when the lip is done, tubes, myringotomy and grommets will be performed by the ENT doctor, and we have an ENT doctor who's part of our team who's come here several times before and is ready to come again. But we want to make sure that the hearing is preserved. We want to make sure that the baby is nutritionally healthy so that it can undergo the operation very safely. And then Diane's going to talk to you all about speech. Pharyngeal flap is something that is necessary in about 10 to 15% of patients. With early care, a lot of that number can be lowered even more. We talked about the dental and alveolar care. Cheryl mentioned that the palate is not missing bone, it's separated, and we only put, as you'll see in a slide, the soft tissue of the palate together. That's all that's needed to be put together, but the gum actually does need bone, where that gum is brought together, but it has to be filled with bone because the teeth are usually all there. If there's any missing, the teeth can be arranged orthodontically to give the child perfectly normal looking mouth, but there has to be bone there for that developing tooth to erupt. So that's usually done about 8 years of age. Sometimes the scar tissue from fixing the palate can require the child to have jaw surgery when they're fully grown, which in a girl can be as young as 16. Boys are always slower than girls, sometimes 18 years of age. The other things that need to be done when they're fully grown is if the septum is still deviated, if the alar cartilage is still collapsed, if there's any final scar revision needs to be done to the lip, that's the ideal time to do it. But the amazing work that Cheryl does to shape that nasal cartilage, if that can be done early on, then it usually prevents a lot of that further surgery down the line. We just have very, very caring nurses who they're preparing a little baby for surgery here. Just a beautiful mother getting her precious baby back after surgery. This was the first Mennonite patient that we did many 23 years ago, and it just opened the door to the Mennonite community. As everybody knows, are a big part of not only service from LEAP, but service to LEAP and to Northern Regional Hospital. And this is the ideal time to do the lip surgery at about 3 months of age. It can be done at any age. This is 47. I wish Cheryl could tell this story because she tells it so much better than I do. But when we first started going to the Dominican Republic, this type of care wasn't available. And so this guy had lived his whole life. He actually got married and raised a family. And when he heard that our team was coming, he traveled 5 hours to see us. And he said, I want you to make sure you take care of all the babies first. If you have an opportunity to fix my lip, I've made it. I've lived all my life, but it's always been a hindrance to me. And when I go to heaven and meet the Lord, I want my lip to be intact. That was actually his sentiment. And absolutely, we finished all the babies and children that we needed to do and worked late at night to make sure that he got his dream of having his lip repaired. We fixed a 74-year-old woman with a cleft lip when we first went to India, who was in a similar situation, waiting all her life, but never had the opportunity to have it done. This is a diagram of the surgery. Again, we don't want to get too technical here. We're gonna always be available for this. We do want to identify if the right person comes along, surgeon in Belize, and that could be an oromaxillofacial surgeon, that could be an ENT surgeon, that could be a plastic surgeon, that could be a pediatric surgeon who just has a desire to learn this type of surgery and scrub with us and let us teach them. And this is called a rotation advancement. As Dr. Sherman said, all the tissue's there. It looks like it's missing, it's just separated. So that's why her role in bringing that tissue together is so important, because it makes the surgery much more reliable. When we first went to India, the operating room wasn't safe for us to do babies. Most of the babies were malnourished. Dr. Sherman started making them appliances and help and teaching the mothers in feeding. That's again when we decided we were gonna come back every year, that this wasn't a one-year commitment. When we went to India, we went to a remote part of India, in central India, and we got off the train because that was the only way you could get to the town that we went to of more than 1 million people. There were 300 cleft patients waiting for us outside the train with wreaths, just celebrating the fact that we were there and nobody had been to that part of India to fix clefts since 1947, the independence of India. And it was too dangerous to do the babies, so we prioritized doing young women, because in that culture, young women get married at a very early age, and if they don't, sometimes they don't have the chance to do that. So while we were preparing the babies nutritionally to come back and do them, and while we were making sure that we helped outfit the operating room so it was safe enough to do them, we prioritized doing the young women. And so this is a baby with a complete cleft, and this is a unilateral, one side. She'll show you bilateral. I'll show you a couple more of those. It's not important, again, that you know all the classification, although Diane's going to give you a great, easy to remember classification, and all this is going to be up on our website to refer back to. The treatment's basically the same. There's modifications that need to be done, but the hope and the outcome is all the same, no matter what the baby's born with. And this is a diagrammatic example of what Dr. Sherman does to us and what even just taping the lip will help to accomplish. Imagine you were building a house and you had to put the house over that big hole in the ground. It would collapse. And the same thing happens if you try and bring the lip together. If you try and reshape the nose, it's all going to collapse into that hole. When Dr. Sermon finishes her work, not only is there a solid platform for that lip and the nose, but the lip is much closer together. There's much less tension on the scar. It's a much better scar. It's a much better result. The shape of the nose is almost impossible to recreate when it's flattened out like that. When Dr. Sermon gets finished, it's a nice, beautiful shape that can be easily fixed. This is one of my patients from Dallas, just showing her several years apart. Again, she had great result. Dr. Sermon said that we've been working together for 31 years, so it's a real pleasure to see our patients grow up, and many of them graduate from high school and even from college and go on to have families of their own. But this is Dylan. We fixed his cleft lip when he was a baby, and he became captain of his high school football team and also went with us on a mission trip to Haiti. Again, this is the hope that we want every child to have. This is a patient from India. When we're working our way down to the younger and younger babies, this is a bilateral cleft lip and palate. You can see it's on both sides rather than just one side. This is a bilateral. It's incomplete, meaning it doesn't go through the nose and the palate on the right side. It's complete on the left side, meaning it goes through the lip and the palate. Again, not important to really differentiate, other than there's a few adjustments that we make in both the way Cheryl treats them preoperatively and the way we treat them surgically. Bilateral cleft lip and palate. Before and after. Cleft palate. This is the nose, and you can see this is a bilateral, so a unilateral tends to distort. This is the septum. You're looking up at the partition through the middle of the nose that separates the right and the left side of the nose. In a unilateral, it's usually severely distorted to one side. In a bilateral, it's usually not distorted because it's got equal pull from both sides. But you can see, and Diane will get into why this causes so much difficulty with the speech when there's no separation from it. But the way the surgery is done is we make incisions on the inside. We make incisions on the outside. There's an artery that runs right there that keeps all this tissue healthy. This tissue is peeled away from the bone, which it's a little bit more dangerous. It's not dangerous if it's done right, but it really has to have an experienced person not only doing the surgery but the anesthesia, because you are peeling that tissue off of the bone, and there can be a lot of bleeding from the bone. So the anesthesiologist's job is to make sure that the blood pressure doesn't go up too high when the baby, even though he's asleep, feels that tissue being separated from the bone. But that tissue is all brought together. And again, this portion, we don't need to worry about the bone. We just need to bring the soft tissue together. It's brought together first at the layer of the nose, the bottom of the nose, then the muscle layer in the back, which is so important in speech, and mucoperiosteum of the soft palate, which is what you look at when you look inside at the roof of the mouth. And this is where the bone needs to go when they're 8 years old, because that's when the teeth, secondary teeth, the permanent teeth, are ready to come through that, and they won't come through a space or scar tissue, but as long as there's bones there, it will erupt through that bone. This is the device that we use to fix a cleft palate so that we can work inside the mouth. It's a special retractor that connects to the lip and opens the mouth and lets us operate in there. This is one that you need to be aware of when it's born. It's a cleft palate, but the real thing that you need to notice here is the chin is so far back, and that's called Pierre Robin. And it's a sequence, because the sequence of the very small chin not bringing the tongue forward makes the tongue fall back, and these babies can have a very difficult airway. And usually it can be easily corrected by having the baby sleep on a stomach. Most of the time you don't want the newborn sleeping on the stomach. In this case you do, because it brings the tongue forward and allows the baby to breathe. Or, you know, if you are in a situation like this with a newborn, then an oral airway put in will bring the tongue forward and create that space. A tube nasal trumpet going through the nose behind the tongue will help do that. But it's just a type of cleft palate that is so different, because this is the one that can cause severe airway problems and even death in the newborn phase if it's not recognized, but it's very easy to recognize and treat. Again, our goal is to train local surgeons. This is our surgeons training some surgeons in Haiti, me training a plastic surgeon in Zimbabwe, and she's doing the cleft lips and palates on her own now. So Mary's gift, I want to make sure that everybody understands that, because we're throwing a lot of technical stuff in here with cleft lip and palate, but Mary's gift is the program that is going to allow all this to happen. And really all it means is that when any baby is born in this country anywhere with a cleft lip and or palate, that they reach out to Diane, and hopefully soon we will identify the person that will be here at Northern Regional to help in that assessment. And we give the parents hope. We supply the feeding supplies. We supply the tape and the things necessary to start taping the lip, and they have immediate access to seeing before and after patients and get on the surgery schedule, either of our team or a team that's qualified to do clefts when they come. And if we identify that there's a need to do smaller trips in other parts of the country, then we're very happy to do that. So,
do we have questions for Dr. Hobar?
Not surgical, but do you guys have like the idea of how much this would cost us a person if they have to go through and paying for the services?
In the
Of
U.S.
everything?
or in Belize?
Well, in the U.S.
Oh my goodness.
a lot of money. It's very expensive, and health insurance will cover it if they have health insurance. We're blessed in that we have a lot of complaining about our healthcare system, but it's really very, very good, and I've never had to compromise on doing everything that I felt was in the absolute best interest of my child and their family, regardless of their economic background or anything else. And we want to help provide the same thing in Belize. And we know this is one problem, and there's a lot of birth conditions that need special care. This is something that we're very good at. We know we can do this. We know that we can work with you guys. We know we can do it safely. We know we can change numerous children's and families' lives, and but we also hope it will inspire other programs to visit with you guys about other malformations that you need help with and do similar things. So we're focusing on what we know best and what we can do best, but the idea is to help figure out how we can help in other ways together with other teams as much as possible.
Another concern that's possible we need to discuss is migrants. I know that we have had in the past people coming from Guatemala to come and see you guys in regards to this. So when it comes to Mary Gift, what if somebody knows that?
Outside of Belize?
Yeah, I think it's a great question. I think the one thing that we are very sensitive, because we've been doing this for 31 years, that we know that it can be very disruptive for a team to come in and for us to take care of a lot of patients. And you guys have never ever complained about that, and you guys always rise to the occasion and do whatever needs to be done while we're here and after we leave. But we don't want to do things that are going to overburden the healthcare system here at all. But we're open. I mean, if they come here and you guys tell us it's good, then we're going to take care of anybody wherever they come from. Any other questions?
Let's have baby born like today, and you are not here. So when that baby get discharged, the baby should wait until the year that you all come back, so that the baby.
I mean, it's a great question. As we talked about, the ideal time to do the lip repair is 3 to 4 months of age, because that gives the best chance, which Diane will talk about, for speech and a lot of other things. But it can be delayed, and we're going to start coming twice a year, and we'll coordinate with the hospital when the best times for that are. We'll have plastics available for clefts on both trips. Our skin cancer will do one of the trips, and our eye team will do the other trip as a counterpart. But what we hope to have in place somebody in this hospital who can work with Diane and visit with the mother and send them home and instruct them in the taping and the feeding, give them the special bottles and the breast pump. And then again, if there are other teams that are coming here that you guys have worked with and do clefts, I know there's a team from Virginia that's qualified to do it. So we want to work together to get as close to these ideal time frames as possible.